Thank you, Willem. Thank you for saving the best for last. Okay, so you've heard three different guidelines, and I'm going to try and be brief because, as all the previous speakers have demonstrated, that we share a lot of commonalities in what we want to achieve. And you may wonder, because the European guidelines came last, people might wonder, were we just looking for a line on our CV for this publication? Or was there a real need for Europe to have yet another guideline for training neonatologists in echocardiography? And I'm hoping to convince you over the next 15 minutes or so that we do need a separate guideline. So those logos are probably going out of date as of this morning, as they're both kind of being amalgamated into the European Board of Neonatology. But as you can see, this recommendation came from almost an international kind of conglomerate of people from North America, from Europe, from the Middle East, and from Australia as well. So we wanted to have something that would hopefully be applicable all across Europe and in other jurisdictions that would like to embrace it as well. Patrick has spoken about this, and just a disclaimer, I did steal a lot of slides from Patrick on my way from Toronto back to Ireland, so you'll be seeing a lot of his slides as well. But we all agree that we need to move away from this traditional echo model, where a clinical question is asked by a neonatologist and somebody parachutes into the neonatal intensive care unit and performs an echo where they are really detached from the clinical situation and detached from the physiological environment and not really knowing the patient in great detail. The image interpretation is often done in a different site by somebody that, again, is unaware of the clinical situation, and you get a report that more often than not will not answer your clinical question. And there is a disconnect between clinical questions and study interpretation with a lot of missing information, and crucially, there is very limited ability to perform sequential scans. And again, out of our studies, is usually limited to answering questions as to whether a child has congenital heart disease or not. You've seen this, and this is a slide I stole from Patrick, but I just changed the top line. What is neonatologist-performed echo? Well, it is an extension of our clinical examination, and it is not confined to the heart, where we also assess other organs, more importantly liver and the brain for line placement and also blood flow to the brain. We usually look at ductal evaluations, pulmonary hemodynamics, and LV performance. And we relate the information we get from echo with our clinical findings and provide a focused and a targeted plan to that specific situation, and we're able to actually look at the response by performing serial studies. Because this is the model that we need to be moving towards. Neonatology, as all the speakers have highlighted, is not simple. Sick babies is not simple. Although we sometimes strive for simple answers, really we need to integrate clinical and echo findings in a more integrated way to come up with a proper management plan. I'm glad to see that these words, logic and reason and competence, and first do no harm, have already appeared in the slides, because it's very important that we should all have common guiding principles to all the consensus statements. That, first of all, if you are going to perform an echocardiogram, you must be competent and you must have completed a recognized training program and met some sort of criteria for image acquisition and, more importantly, image interpretation. You must have logic and reason, because you need to use what you find in the context of the clinical scenario. If your images do not make sense, or if they lead you to a different path to what you were thinking about, then you need to actually take a step back and have another think about it, and maybe seek expert advice as well from other specialties. You also must be competent. Your image qualities must be adequate, because, as Patrick has taught me when I was going through the neonatal training in Toronto, garbage in, garbage out. If you have rubbish images, you may make incorrect interpretations of what you're seeing. So, why did we come up with new guidelines? I didn't put Nick Evans' guidelines here because I think the Australian and New Zealand guidelines have actually done a fantastic job of meeting the need for the Australian and New Zealand subspecialty in neonatology. But when we actually looked at the expert consensus statements, both from Europe and from North America, we found that, as Jogan has presented, there's an over-reliance on our pediatric cardiology colleagues for training neonatal specialties. And I think that already creates a detachment from what neonatal performed echocardiography should be all about. You can see here that you need a 12-month placement consisting of at least 6 months in a pediatric cardiology center, and that you need to attend a lot of cardiology outpatient clinics. And each neonatal consultant needs a designated link to a pediatric cardiologist, and also, once a neonatologist is fully trained, they need to keep attending pediatric cardiology outpatient clinics. So as you can see, there's an over-reliance on pediatric cardiology services for training and also maintenance of skills. What about the North American guidelines? Patrick hid these paragraphs from you, but again, they advocate that the training should be conducted and directed by a pediatric cardiology laboratory. And again, the training should also start in a pediatric cardiology environment as well. So as you can see, training and supervision has been recommended to be under the guidance and governance of pediatric cardiology, and is very focused on congenital heart disease, because they mandate that the majority of the scans a neonatologist starts with should have congenital heart disease. Now, I know that that doesn't actually happen in reality in North America anymore, so they're already moving away from the recommendations. So what are the challenges in Europe? We are very diverse. There are many level 1 and level 2 units, and there's a lot of standalone level 3 maternity units, which, if I'm not mistaken, is pretty kind of unique to Europe. There are many neonatal units that are co-located with adult services, and also quaternary maternity units located within children's hospitals. So as you can see, there's a diversity of the type of care we provide. So what are the challenges with pediatric cardiology? Well, in Ireland and in many, many places around Europe, there is no proximity between pediatric cardiology services and NICUs. And pediatric cardiology services are already under pressure. They can barely train their own trainees. In fact, my first 2 trainees that have gone through the neonatal service were pediatric cardiology trainees that ended up doing pediatric cardiology because the services there could not accommodate their training needs. And they're also not adequately resourced to take an influx of neonatologists or neonatal trainees to train them. And I'm sure you'll understand, you'll appreciate that us as neonatologists cannot really do or part with our neonatal trainees who provide a service for 6-month periods at a time to go to an echocardiography lab and learn how to image children, infants with congenital heart disease. And what you need to realize is that when you go to an echo lab as a neonatal trainee, you will not be echoing babies, you will be echoing children, which again, there's a big detachment between what you really need to do on the clinical ground and your training. So as a result, a one-size-fits-all approach in Europe is really not feasible. And you've seen this slide before from Patrick, and this is something that absolutely needs to be done in all intensive care units that care for sick neonates. But what is important, and we must not forget, is that there should be collaboration with the pediatric cardiology service, not for training, but for support in all of those domains that you see up there. So how do you achieve this model of care? Well, we think that training should be governed and conducted by neonatologists, and that it should be carried out in the neonatal intensive care units, where you will use the skill that you have learned, not away in a dark echo lab somewhere else. It should be achievable, and it should be disseminatable. We should try and train as many of our colleagues as possible to acquire this skill, and many of you that are here are obviously here because you realize how important this skill is to have. We should emphasize confirming normal structural anatomy, rather than diagnosing different congenital heart disease structures. And we must emphasize functional assessment and management, and integrating what we find with clinical care. And we must have a strong and close collaboration with pediatric cardiology. You've heard a lot about the terms, and I'm not going to kind of dwell on it, but we felt that we should stick to the term echocardiography, because really that is what we are doing. We are doing an echocardiogram, and we felt that having a name depicting who's performing it would provide enough clarification as to the type of studies that we are doing. So, what about training requirements? We felt that we should actually provide guidance on which centers are able to train people. We are currently working on getting accreditation through an overarching European body. We are in the early stages of that. We're not as close to Patrick in getting accreditation through Canada, and obviously Nick has well-established accreditation program as he's described. So until then, we felt that we should actually describe which units should be able to actually train. And this just reflects the level of complexity that the trainees should encounter when they're doing their initial training. So for example, the unit should be a tertiary unit. It should ideally admit children with congenital heart disease that is discovered antenatally, and this will provide an ideal ground for exposing our trainees to recognizing congenital heart disease patterns within the neonatal setting, because that's what they need to learn. They need to learn how to recognize congenital heart disease in early neonates and their early management prior to them going to cardiology services. There should be regular on-site pediatric cardiology to provide training, collaboration with research, and also support for managing children with congenital heart disease. It should be an accredited training center within the country, and it should have all the modalities that is needed to kind of manage sick babies. What about the trainers? Well, the trainers should actually have formal exposure to congenital heart disease, because they need to be able to describe what they find and teach their trainees pattern recognition as well. And they should have formal links with pediatric cardiology. We also have specified pre-training phase for candidates, and we're working with Europe to have something like we had in the early pre-course, where you have an echo course that deals with basic cardiac anatomy, physiology, and hemodynamics, and also basic principles of physics and ultrasound. I know the Australian model has a much more robust requirement for a course in basic physics of ultrasound. We haven't mandated that, but we highly encourage people attending courses that give a basic overview of physics of ultrasound. And the candidates should actually be familiar with the echo views and recognition of structures in various images, and attend a basic echo workshop just to get a flavor of what they're about to embark on. So I'm not going to dwell on the training because everybody can read it, but the training is focused to be in the neonatal intensive care unit. The emphasis is on children with functional abnormalities, with normal structural anatomy, and really you could see what we have kind of suggested as a basic training, advanced training, and then maintenance of skills. We felt that you need to do a minimum of 100 scans before you could even be considered as basically competent in echo, and it is up to the trainer to decide whether that person has achieved that level with 100 scans or more scanning needs to be done. We have also tried to integrate simulator training for the early phases of training. We recognize that people that are embarking on neonatal echocardiography will take time to acquire the images. They may become stressed in an environment where a baby is becoming destabilized. So we felt that the early image acquisition should, if available, happen on a simulator so that they become familiar with the probe positions and that they become familiar with the echo views. And as you can see, there are very high fidelity simulators that are currently available on the market, and we have integrated that into our training in Ireland. Other important practical aspects, we've described the care for preterm infants within the guidelines, and also had some sort of emphasis that the first scan should really document normal structural anatomy. Before you do anything to intervene, such as closing a duct or managing pulmonary hypertension, you really need to be competent enough to be certain that the heart is structurally normal. Because if you cannot do that, you may cause more harm than good, as Patrick has described previously. Congenital heart disease is a real problem in preterm infants. It happens overall about 10% of the population. So you will encounter it in your escapades as a neonatologist performing echocardiography. So we should be able to recognize congenital heart disease and make the appropriate referrals to the appropriate services. And my colleague Aisling Smith will present her paper next, demonstrating that there is a very high incidence of other unrelated findings that you must also be competent in demonstrating. And we have suggested what should be documented in the first study to confirm structural anatomy. And we've also kind of recommended on repeat scans what you should document with each study to make sure that whatever changes you have made in the management, that you haven't kind of unmasked congenital heart disease that is there, and that there is no progression. For example, pulmonary stenosis is usually not there in a baby at 24, 25 weeks, and it is something that can become more apparent as the baby becomes closer to term corrected. So we must also be cognizant that that even structure is a dynamic thing that could change, and our follow-up scans should look for things as they evolve. What we're really, I suppose, happy with and proud of, that we have very comprehensive guidelines to follow this consensus statement that will be published in an open access format, free of charge in pediatric research in the early new year, that will really go into all the kind of clinical scenarios, description of how to measure function, to really give an overall comprehensive appraisal of what neonatologist performed echocardiography is all about. So, to conclude, NPE is an evolving practice in Europe, and the pace of its evolution and uptake by neonatologists is increasing rapidly. Locally in Ireland, in my centre, I have completed training of 4 candidates, and as I have said, 2 of them have actually crossed to the dark side to go on and do cardiology, and the cardiologists were very impressed with the level of skill that they have acquired during their neonatal training in our neonatal centre. And there are 2 others that I'm glad to say are staying in neonatology, and we're currently have just started training 3 others. So over a course of 4 years, we have trained 4 candidates and are about to train 3. I think adherence to training guidelines and continued collaboration with pediatric cardiology is of paramount importance. And hopefully this statement can serve as a foundation upon which each country can base their national guidelines on, given their specific logistical characteristics. Thanks very much.